The excellent talks. Thanks to Manu for offering to take the pressure off. I really appreciate that, actually. And I totally agree that we need multiple different approaches to phenotyping because one is not going to be the answer. But that's not actually the main topic that I was asked to cover today. So I'm going to be talking about vitamin C and statins. Are there indications in ARDS and sepsis? Because I agree also with Manu that I think it was either Gordon Bernard or Taylor Thompson that said ARDS is sepsis on a ventilator. So I think we're talking about the same thing. These are my disclosures, none of which are actually relevant to what I'm going to talk about today. All right, so let's start with statins, and I have to start with this picture of my good friend and colleague, Danny McCauley from Queen's University Belfast, who, as we've already heard today, is a diehard statin enthusiast and who was gracious enough to share some slides with me for this presentation. So I'm going to start with just some review on mechanism of action and some preclinical studies, and then talk about data in ARDS and COVID-19. And so Manu already laid the stage for this slide, which is just to remind you that we're talking about HMG-CoA reductase inhibitors in statins, best known for their effects on cholesterol, but also potent anti-inflammatory agents. And that's the proposed mechanism of benefit here when we're thinking about ARDS. There's actually quite a bit of preclinical data that suggests that this might be a good idea. This is data going all the way back to 2005 from an LPS lung injury model in which you can see improvement in histologic lung injury with simvastatin, decrease in bronchoalveolar lavage albumin, myeloperoxidase activity, and PMNs. Dr. McCauley and colleagues have also studied this in the inhaled LPS model, where healthy human volunteers are pre-treated with simvastatin versus placebo, then inhale LPS and undergo bronchoscopy. And if they're pre-treated with simvastatin, you can see that simvastatin decreases pulmonary TNF-alpha in that context, providing, again, some preclinical support for this idea. In patients undergoing esophagectomy as a model of lung injury because they have one lung ventilation, pre-treatment with simvastatin decreases alveolar epithelial and systemic endothelial injury. As you can see, the figure on the left-hand side shows levels of RAGE, the receptor for advanced glycation end products, which is often used as a marker of type 1 alveolar epithelial cell injury. And you can see that the simvastatin patients have lower levels of RAGE over time, and also lower levels of urine albumin creatinine ratio, perhaps relating decreased systemic endothelial injury. And while this study was quite small with only 15 patients in the simvastatin arm and 16 in the placebo arm, you can see that the clinical data certainly looked on the favorable side for simvastatin. All right, so this all looked exciting, promising. So Dr. McCauley and colleagues then conducted the HARP-2 study, simvastatin in ARDS, 540 patients. And what did they find? They found no difference in the primary outcome of ventilator-free days, with a mean difference that was suggestive perhaps of benefit for simvastatin, but certainly not clinically significant. And in fact, here's the survival curve where you can see maybe simvastatin slightly nudging out placebo, but certainly not statistically significant. So this was obviously disappointing in the context of all of that preclinical data. Now, the one-year outcomes did look slightly better, again, for simvastatin versus placebo, but still not clinically significant. All right, we've talked quite a bit already in this fantastic session about the idea of phenotypes, endotypes, and treatable traits. Phenotype here being ARDS, okay? Subphenotype being a subset defined typically by multidimensional data. Endotype being a specific subphenotype that has a particular predictable response that's linked to therapy, that's linked to the mechanism of that endotype, and then a treatable trait perhaps being an endotype that actually crosses syndromic definitions. And this is from a fantastic review in Lancet Respiratory Medicine by Kiran Reddy and colleagues from a few years ago, this figure. So we've already talked a little bit about the so-called hyper and hypoinflammatory phenotypes and how might this play into the simvastatin story? So this was a secondary analysis that we did along with Danny of the HARP-2 study, in which you can see that survival and response to simvastatin seemed to differ on the basis of inflammatory phenotype. So if you were in the quote-unquote hypoinflammatory phenotype, really less inflammatory than the other one, in the light blue or dark blue lines, it really didn't matter whether you got simvastatin or placebo. However, if you were in that hyperinflammatory phenotype, as you can see, is that working? Ooh, it's working, how exciting. Here, there appeared to be a survival benefit. Now, this is a secondary analysis. It needs prospective validation and certainly should not be taken as anything that should influence patient treatment, but suggestive, again, of this idea that there may be a treatment-responsive subset within this broader phenotype of ARDS. Now, in contrast, we took a similar approach in the SAILS trial of rosuvastatin. So this was the ARDS Network's trial of rosuvastatin versus placebo for infection-related ARDS. It was a negative trial, as you can see from the survival curves on the left-hand side. And we were so excited. We got that data from the HARP-2 trial, and we thought, ooh, well, maybe it'll be the same in SAILS. It certainly was not. So here we saw no evidence of a subphenotype-specific survival benefit with rosuvastatin. Why might this be? Well, we can think of lots of different potential reasons. It could be dose-related. The dose that was given in the SAILS trial was actually relatively low. But I think it might actually, it could be certainly chance also, right? That's always possible. But I think it might be related to this issue of statin lipophilicity versus hydrophilicity. It turns out that statins exist on a spectrum in terms of their lipophilicity, with those that are more lipophilic, like simvastatin, having higher extrahepatic tissue penetration, and those like rosuvastatin that are more hydrophilic being more hepatoselective. And so it would stand to reason that perhaps the ones that are more lipophilic would have better potential for being useful in ARDS and sepsis. And in fact, most of the preclinical data, it turns out when you look back, does come from lipophilic statin models. So take that with a grain of salt. Now, what about COVID-19? So there's actually been quite a bit of data in this area. This slide shows data from almost 14,000 patients in Hubei province from early on in the pandemic, and 28-day all-cause mortality, as you can see from the figure on the right-hand side, was substantively lower, statistically significantly lower in patients on statins versus those who were not, after matching for other comorbidities. This is another study published in Nature Communications that used a propensity matching approach to try to consider confounding by indication and adjust for that, and found, again, lower mortality, better outcomes, less vasopressor use in patients who were treated with statins. And a systematic review published also in 2021 found that after adjusting for differences between statin users and non-statin users, overall the effect of statins on the hazard ratio for in-hospital mortality and severe disease was beneficial. All right, but that's really all observational study. Tomorrow, Dr. McCauley will be presenting the results of the REMAP-CAP simvastatin study, which tested simvastatin 80 milligrams during the pandemic for moderate and severe COVID, with treatment lasting up to 28 days. So stay tuned for the hot topic session tomorrow in the Gold Plenary Room, where Dr. McCauley will enlighten us more on this topic. All right, so in the remainder of my time, I'm going to talk about vitamin C. And really, what are the potential benefits of vitamin C? Why might we think that it'd be beneficial in sepsis and or ARDS? Well, it has multiple potential mechanisms of benefit. It's a known antioxidant, so it may reduce oxidative stress. It has anti-inflammatory properties. It may improve endothelial function. And interestingly, it can't be synthesized by humans, and we have limited stores, and frequently patients who are critically ill with ARDS and sepsis, when measured, are more vitamin C deficient compared to normal humans. And while there's not as much preclinical data on vitamin C as there is in general for statins, there's some considerable evidence. I'm showing here some data from an LPS lung injury model in which vitamin C, abbreviated as ASCA for ascorbic acid, did improve survival and improved histologic lung injury. And if you'd like to go through that preclinical data in detail, there's a nice review from Critical Care 2014 that I've referenced here. Now, in contrast to the maybe less well-developed preclinical data, there's actually an absolute ton of clinical data on the topic of vitamin C and sepsis and ARDS. When I searched this just in clinical trials, 57 clinical trials in PubMed over the past 27 years. Now, it's mostly in sepsis rather than ARDS, but because I agree with Dr. Shankar Hari that these are very closely related syndromes, I'm conflating them in this presentation. I am not going to review all 57 of those trials, but I'm going to focus on some of the key data. And you have to start, I think, with this trial that really got the conversation started in, study, let's call it a study, that really got the conversation started in vitamin C. And this was Dr. Merrick's study of hydrocortisone, vitamin C, and thiamine for the treatment of severe sepsis and septic shock, where you see quite a big difference in the treated patients and the control patients. But it's really important to emphasize that this was a retrospective before and after study, not a randomized control trial. So what happens when we study these in larger randomized controlled trials? So I'm just going to hit some of the highlights. One of those was certainly the Citrus ALI trial published by Barry Fowler and colleagues in JAMA in 2019. This was vitamin C infusion for patients with sepsis and severe acute respiratory failure, mostly essentially acute lung injury. Now, the primary endpoint here was the modified SOFA score, which you see on the left-hand side, and that was negative. Okay, so did not achieve statistical significance. However, if you look on the right-hand side and you see all-cause mortality, wow, that looks like a drug that I would want, right? Vitamin C looks a lot better than placebo. And so even though that wasn't the primary outcome, this certainly caught a lot of people's attention. Okay, cut to 1 year later, JAMA 2020, the vitamins trial led by Tomoko Fuji and colleagues. This was vitamin C, hydrocortisone, and thiamine together versus hydrocortisone alone. So a little bit of a different research question here. But now look at our primary outcome, time alive and free from vasopressors, no statistically significant difference, p-value 0.83, starting to look a little more confusing. This is the survival curve from that, and now look, now maybe you don't want that drug. The intervention is on the wrong side of the survival curve now, so starting to get a little bit murkier. And if you thought that was murky, then the Levitt trial published last year in the New England Journal made this even murkier. So this is Neil Adkari, Francois Lamontagne, intravenous vitamin C in adults with septic shock. Now what do we see? We see that vitamin C caused increased mortality. Oh boy. All right. So what do we do in this situation? Well, we turn to meta-analysis. Okay, this is kind of a consistent theme from this session, not that different from Dr. Rainieri's. We have lots and lots of data, and we still have a lot of uncertainty. So this was a meta-analysis published in Frontiers in Nutrition 2023. I'll draw your attention to the summary estimate, which is slightly towards vitamin C, but not statistically significantly so. Okay, well, if you don't like that meta-analysis, you could use this systematic review, which gave a different answer, where here the risk ratio is 0.73 and, in fact, in favor of vitamin C. And if you don't like that one, you could turn to this one in New England Journal Evidence, published in June 2022 by the authors of the Levitt trial. This was really quite scholarly, included 37 studies in the meta-analysis, and I'll draw your attention to these plain language summary, which I think is really helpful. So let's just read these one by one. So parenteral vitamin C probably increases risk of in-hospital mortality. Parenteral vitamin C may reduce risk of 30-day mortality. Parenteral vitamin C may reduce risk of early mortality, and parenteral vitamin C probably increases risk of 90-day mortality. So talk about confusing signals. All right. Well, I'm really hopeful that we'll get more clarity tomorrow. So Neil Adhikari will be presenting the results tomorrow of the REMAP-CAP LOVE-IT COVID trials. These are focused in COVID. They have some slight differences, as you can see from this slide. So LOVE-IT COVID did not include patients on vasopressors, in part because of, I think, the results of the LOVE-IT trial, which was patients with septic shock. Was based in Canada with 750 patients, a blinded trial. In contrast, REMAP-CAP was unblinded with the Bayesian design, and of course, worldwide. I do not know what the answer is for this, and I'll be really excited to find out if this will enhance our clarity. All right, so to summarize the take-home points, I think there's really strong preclinical and early phase clinical data that lipophilic statins may reduce lung injury, and moderately strong preclinical data for vitamin C, largely in sepsis. But large clinical trials for statins for ARDS have really been pretty consistently negative. There is suggestion of benefit for simvastatin in the hyperinflammatory phenotype and some supportive data for COVID-19. Really now dozens of clinical trials of vitamin C for sepsis and ARDS with really confusing results. I would say it probably doesn't have a large mortality benefit, but maybe that'll be wrong when we see the data from COVID tomorrow. It may cause harm, and I always wonder when I see trials like this that have such conflicting results for what should be essentially the same intervention in critically ill patients if we're just seeing different subgroups. If we're seeing different subgroups, subphenotypes, endotypes, call it what you will, that are being treated, and so that's why we're getting different messages. But there's more data coming on both tomorrow, so go to the Hot Topics session and learn more. Thanks so much.
Great talk. You got us very confused now. I guess the question that lays at front is, what is your idea about these conflicting results in terms of phenotypes? Do you think that there is a response in the hyperinflammatory, as you saw in your other analysis of interventions, or do you have the availability to look at this in these data?
You mean in vitamin C?
Your hypothesis?
That's a great question in vitamin C. I think Dr. Shankar Hari summed up a lot really well in that last presentation, and one of the things I really liked was the focus on uncertainty. And I think we really don't understand what the mechanism of differential treatment response that we've observed in this so-called hyperinflammatory phenotype. We really don't know if inflammation is the cardinal difference between those two phenotypes. On the basis of what we'd observed, you might hypothesize that vitamin C would be more beneficial in that hyperinflammatory phenotype, but I really worry in this field. My biggest anxiety in this field is that we will get out ahead of our skis, basically, and think that we know more about mechanism than we do, and inadvertently have a mismatch between treatment and mechanism in one of these subphenotypes. So I think the answer is going to be in prospective RCTs that try to address this. Dr. McCauley is leading one that will hopefully be starting within the next year or so, called the Panther trial, which will be an adaptive platform trial that's designed ahead of time to be subphenotype informed and stratified. So hopefully trials like that will help us be able to test some of these questions in a prospective way.
If I may ask a more general question in follow-up to your comment. If you look at what you've shown for vitamin C and the proposed effect of vitamin C, it's basically inhibiting everything. How much biological plausibility should we have before we actually embark upon clinical trials?
Yeah, that's a really great question. How can we design our preclinical studies to increase our chance of identifying a benefit? Right? I think in the case of vitamin C, there was actually pretty decent preclinical data that suggested that it might be effective, and yet we have these wildly different results, right? Ranging from proposed large benefit to proposed significant harm.
Yeah, but the preclinical data are very often obtained in suboptimal models of sepsis and ARDS, where basically there's no treatment.
Yeah. Totally agree.
We give antibiotics to our patients and very rarely to the mice we treat.
Yeah.
And again, going back to fundamental immunology, I'm not sure I would like inhibition of NF-kappa B if I have infection. So if you inhibit about every single pathway with miracle drugs such as vitamin C, with I would say little biological plausibility that we are going to have an effect. And if we also fail to measure what's going on in the patients we treat, because I believe that there are no negative trials. The negative trials are the trials we don't do. But at least we should collect enough material so that we understand what happened in the patient that responded and in the one that did not respond.
Oh my gosh, I couldn't agree more. I have so many thoughts on what you said, but I'm going to try to contain them because I know we're almost out of time. But I think we need to collect biological samples for that reason in every randomized control trial that we do so we can learn what happened. Did we not have target engagement? Did we, help some patients based on their biology and harm others with the treatment? So I couldn't agree more. I also love that you mentioned antibiotics in preclinical models because that I think is so critically important, trying to get our preclinical models to mirror more the human situation. I'm not an animal model doctor. I'm not a mouse doctor myself, but in collaboration with colleagues, I've been so impressed by the differences in, for example, a pneumococcal pneumonia model in mice with and without antibiotics, right? You might notice most of the data I showed you here from animals was an LPS, right? Which is really not something that humans ever get other than in preclinical models. So I think we have a lot of work to do on the preclinical side to improve our models and on the clinical trial side to make sure that we learn as much as we can from those trials.
This is a short response to that. We do have endotoxins circulating, which is quite similar to
well, that's
what is
true.
being injected in.
That's true, but not in isolation, right? It's in the context with exactly.
Thank you very, very much.
Thank you. Well, thank you.